Now, if we're looking at toxicologic emergencies, poisoning is common among children, right? Because why? Because children like to put things in their mouth, and they may, inadvertently take medication that they think looks interesting or may actually have some kind of sugary coating on them to make an adult have an easier time swallowing it. They're going to play around with things that are really not great for them, and they can absorb a lot of toxins through that particular substance. This could be anything from gasoline to acetone, other things that are going to make it through the skin barrier very easily, and because they're much smaller in size and they're kind of playing around in some of these chemicals, they can become poisoned very quickly. So here are some of the common things that children tend to become poisoned by, and this is alcohol. If you let a child get maybe a mouthful of rubbing alcohol and they actually manage to swallow it. Regular alcohols that adults might drink, say a rum and coke, where they are unable to actually detect the taste of alcohol in it. Aspirin and acetaminophen, which is your over-the-counter NSAIDs, they can be highly toxic to children. Household cleaning products, houseplants especially, for very small children and infants or toddlers that like to chew on everything. There are many, many houseplants that are highly, highly poisonous to not only children but animals. Any kind of iron supplements, and then prescription medications. There are several prescription medications that are one pill kills. You should probably look that up and try to make sure that you understand that if a child gets a certain dose of, say, perhaps a blood pressure medication, that can ultimately end up killing them if they are not caught and brought to the appropriate facility immediately. Illicit drugs obviously have significant effects on small children, and then unfortunately, vitamins can actually be very toxic if taken in copious amounts, right? And so we've all heard of the Flintstone vitamins, and they taste great, and they have a lot of sugar added with them and fruit flavors. A lot of children will ultimately end up getting into those and eating just maybe a whole bottle like it's candy, and this can actually become very toxic for children. You guys have already gone through the toxidrome questioning, so here's some of the questions that we want to know. What is the substance? How much of the substance was involved in the exposure? When did it happen? Did they vomit up anything if they ingested it orally? What does that patient weigh? And is there some kind of altered behavior or change in their level of consciousness? If the poison is an external contamination, we want to remove any of that from the skin. If it's dry, we want to brush it away before we add water to it, because the water might actually make it absorb more readily. So we'll try to brush away as much as we can and then rinse with copious amounts of water. If there's anything in the mouth, we want to remove any of the remaining fragments or evidence of it from the mouth. And then we're going to maintain ABCs as per normal. If your system allows it, you want to give activated charcoal unless it's contraindicated, and that's for those caustic substances or some of the metals. And just going through your activated charcoal in your medication charts and labs should give you enough of this information. And it's generally 1 gram per kilogram of body weight, and it can go down as low as 0.5 gram. This is really based on what you're able to get them to actually swallow. All right, now we're going to talk about management of fever emergencies. And children regularly become febrile. They have that increase in body temperature due to an infection. And anything that's over 100.4 is considered a mid-grade fever. Generally, now we kind of shifted up a little bit to the 101 spectrum. But if we have 100.4 or higher, we're saying that that's an abnormal temperature, right? So 98.6 fluctuates sometimes into the 99s, maybe a little bit low 98s, high 97s. 98.6 is just the average normal temperature for a human with a little bit of variance. When we hit that 100.4, we know we're kind of stepping out of that range, and now we're kind of into a deviation, and we're going to go from there. Low to mid-grade fevers are rarely life-threatening. It's not until we get into the 103, 104, 105s that we're really starting to become worried about this, and this is where febrile seizures are going to come into play. Common causes of fevers are going to be from infection. Okay, in regards to this slide where it says accurate body temperature is important, this is actually probably the most truth that you're going to get as far as getting temperatures. could be a $3 thermometer to a $600 thermometer. Often they are not the most reliable thing that you're going to get. Make sure that if you take a temperature and it's giving you a digital number, that it at least somewhat resembles what you're feeling with your skin. If that patient feels febrile, they are probably febrile. So don't use the end-all be-all of a digital readout on your tympanic or your temporal. The rectal temperature is usually the most accurate for anyone, but very rarely is anybody going to let you take that temperature. Okay, pediatric hypoglycemia. This can be a life-threatening emergency that requires immediate treatment. Now, you guys will get in lab, we teach D50, D25, D10. Most services are running D10 only, regardless of age, and this is specifically due to the least amount of impact to the patient. And so what I want everybody to understand in regards to dextrose being given by IV, we cause violent swings in blood sugar levels that ultimately end up causing the patient to stay in the facility for upwards of 10 days while they're trying to get their sugars kind of maintained and stabilized. So if at any point you can go to D10, that should be your primary go-to in regards to giving a dextrose treatment for any patient of any age. And remember that we have a general kind of grams per kilogram kind of dose range, but in the case of dextrose, this drug is titrated to effect. We don't want to keep giving them sugar if they are now mentating appropriately or have a normal BGL. We would much rather have that patient eating if it's appropriate, because it's a much easier way for the body to kind of deal with the blood glucose levels. Now, asking a child with a known history of diabetes, if you ask them if they've taken their insulin today, this is obviously a child that's doing their own treatments. This is really dependent on age, and then do they know what their dose is supposed to be? Do they understand how to modify their dose based on their eating habits, or are they put on a very specific dose? And is it short acting or long acting? And is there any kind of other agent that's being taken orally with this? And then you want to know, like, how much activity have they had and what have they had to eat? And the reason that you're really kind of curious about what they're eating is because there's a specific conversion factor to a unit of insulin versus how many grams of carbohydrates they need to be eating. Okay, unfortunately, drowning is the #1 cause for unintentional death among children ages 1 to 4 in the United States. They often fall into swimming pools, lakes, or other bodies of water, but it can be something as simple as a bucket of water. Alcohol is usually a frequent factor when we're talking about adolescents, which is, again, our teenage children that are having some kind of swimming or drowning accident. Okay, so when we're dealing with some kind of drowning, we want to kind of know, do we have a wet drowning or a dry drowning? Most of the time, our drownings are going to end up actually being dry, where the epiglottis slams shut and does not allow the patient to actually inhale water. If they do inhale water, you kind of want to know, was this salt water or was it fresh water? Because it's going to change some of the things that are going on inside the lung tissue based on the salt or the salinity of the water. If we hear wet lung sounds, we obviously know that we have a wet drowning, and that's a completely different kind of management system for you. So this is when you really want to know if you can get a paramedic crew to back you up, if at all possible. We're going to treat the same way regularly, regardless of type of drowning, and that's going to be to get them being ventilated with 100% oxygen, if that's what we need to be doing. If they have some kind of traumatic event, we want to make sure that we have a cervical collar on them and make sure that you get them in the appropriate position. Again, long spine boards are kind of going out of vogue nationwide, so it's not one of those things where we're going to have somebody on a long spine board for very long. And we will keep them on a long spine board if we're performing CPR, if they're in cardiopulmonary arrest. So because we jumped from the drowning, we're going to go into trauma, and that is the #1 cause of death in the United States for children. Infants and toddlers are most commonly hurt as a result of unintentional suffocation, drowning, falls, or abuse. Common causes are automobile crashes, falls, gunshot wounds, blunt injuries, or sports activities. Now in this slide, we're talking about how children are less mature psychologically than adults, which means that their decision-making capabilities are probably not on point, and we ultimately end up having a problem with our risk aversion. So many small children to teenagers are willing to take significantly more risk than adults because of their lack of awareness to the consequences of their actions. Injury patterns are going to change between children and adults, and this is really because of just their physical stature. Child's height is going to put them at a different position towards the bumper at the time of impact as per an adult, where most adults, if they're struck by a vehicle, are going to go up and over the hood. Children often tend to go down and under the bumper. Head injuries are going to be significant bleeds, and this is where children can bleed a great deal. Now I'm going to just touch on this briefly again. Remember that in small children, the ribs have to a little bit more of a cartilaginous kind of structure to them, and you may not see a bunch of snapped ribs or a broken rib cage or paradoxical movement when they're breathing. But that doesn't mean that they haven't sustained a significant injury underneath the ribs or the sternum. Remember that just because their skeletal structure is going to flex a little bit more, they can still have massive injuries underneath without the telltale signs on the outside. You're going to do a thorough assessment. We're listening for breath sounds and making sure that we understand that we can have a hemo-pneumo or a pneumo without anything really looking too terrible on the outside. You're going to manage this the same way you manage an adult. Rehashing the abdominal injuries, it's common in children. Again, that's because they don't have the same muscle structure as a adult does, where the tone of the muscle and the thickness of the muscle is protecting those internal organs. Okay, so when we're talking about injuries to the extremities, there's just a small kind of blurb on here about growth plates, and this is where we can have some weak spots in the bone and they can become injured. If you do injure a growth plate, there is a small risk that there will be some abnormal or stunted growth in that limb. So we really want to just make sure that we're not trying to use adult immobilization devices unless the child is large enough to properly fit in that device. So if you are going to try to do some kind of like traction splint or something like that, make sure that it's appropriate for that actual size of child. Otherwise, you're going to have to come up with something that works for you. The unfortunate truth is that for the most part, most ambulances aren't rigged out or kitted out with adult and pediatric and everything, just because of the low occurrence of significant trauma in children, like I guess per 100,000, right? It's still a low risk event, even though there are high consequences to the event. Burns, as we went through some of the burn stuff when you're doing your Parkland burn formula and stuff like that, we know that the rule of nines is different on pediatrics, and this is just due to the extremity size versus the torso and the head. So just make sure that you understand that the surface area over body mass is completely different in a child, and this can complicate things, and that most children are not able to tolerate the burns as well as the adults, and they may develop shock fairly quickly. Some of the common ways that children are burned is exposure to hot substances, hot items on a stove where they'll pull it off the stove on top of themselves, or they may end up with some kind of chemical burn that's caused by a caustic substance. This can also be an electrical burn where if we do not have child-proof outlets in the house, the children are kind of curious and they may plug something into an outlet and cause themselves an electrical burn. Okay, in this slide, this is pain management, and this is positioning, ice packs, and then, extremity elevation. The common thing for pain management now is fentanyl. Fentanyl works great in children, and the dosing strategy is very similar, at least in our local area, to the adults. So make sure that if it's appropriate to give the child some kind of pain management, give them pain management. We would never want to withhold it just because they're small. We shouldn't be fearful of doing pain control in pediatrics because if you're doing it correctly, there's a very low risk of any kind of adverse event. So I'm going to stay quiet in this slide, and I'm going to let you just kind of look at the Jumpstart pediatric triage. This is similar to regular triage, but there are a couple of other things that you're considering on this, and this is where it changes from somebody going from yellow to red versus a green or the black deceased tag. Again, this is in your book, and you should probably know this. You will see this somewhere on an exam. Unfortunately, we're going to have to talk about child abuse and neglect. This is something that thankfully it's fairly rare to see. We really don't see it very often. When we do see it, it's something that's significantly problematic for all of the providers. And abuse can be anything from neglect to physical abuse, sexual abuse, and or emotional abuse. The book or this actual slideshow is going to have some pretty extreme examples, and unfortunately, we're not really greatly trained on picking up on the subtle signs of abuse. I know that my particular agency, we work hand in hand with our specific law enforcement, and they put on a great class for us to pick up on these small things. If it's something that you're really interested in, please do reach out to me, and I will give you the link to the lecture on that. But it has nothing to do with class. It's just for your own knowledge so that you can actually pick up on very subtle clues in regards to like where the physical abuse starts to manifest and how you would pick up those small signs all the way into some of the neglect and emotional abuse. Again, the child abuse and neglect is a will report, meaning that the state has a law that says we will report any time that we suspect that there's some kind of abuse or neglect going on with a child. There is no ifs, ands, or buts on this. This is anybody from the layperson all the way through any kind of provider. So make sure that you take some pretty detailed notes on any findings that you come up with or any statements or anything that kind of seems suspicious, because this is going to go into a report with the state. They're going to always do a pretty significant amount of investigation on this to see if there's anything that's substantiated and then mitigate the problem. Okay, so here are some of those things I was talking about where we have some pretty significant kind of signs of abuse. And while these do happen, right, you can see on this child's legs, we have what looks to be like a dipping injury where they had their legs put into scalding hot water. And then we have got the telltale signs of bruising and other marks across the back from probably being beaten. And then remember that we're looking for other stuff like the rectal or vaginal bleeding. These are things that you may not pick up on and you're just not actually looking at right away. So anytime that you have any kind of old multiple injury patterns where there's multiple bruises in different stages of healings, this should be something that really sparks your curiosity on this. And what I do want to make sure that we know is that while you may suspect that, that is not something that we're going to have a conversation with the parents about. You may ask like, hey, can you tell me what all these bruises are about? Do not engage them and turn this into a fight with them. That's not your place, right? We're going to get them to the appropriate facility. We're going to make the appropriate report to that agency that needs to have it, and let the responding agency do all the work as far as the investigation. Okay, in regards to abused children may appear withdrawn, fearful, or hostile. The caregiver may give a history of accidents or things that just don't add up to kind of match your injury pattern. Again, this is a must report any suspected abuse. One thing that you should probably think about is if you're in a home that, we'll say there's 3, 4, 5, 6 kind of EMTs, maybe 1 or 2 police officers, all inside a home for a call other than the child, and you have a child that just appears to be sleeping through this like it's not a big deal on the couch or something like that, that may raise a little bit of suspicion for you. This might be one of those things where that's an inappropriate response to a lot of people that are in the home that normally would not be in the home. So, you might not be in, you might not actually be in a home to actually assess a child, but take good care of looking at your surroundings. And when you see children that seem to be inappropriately interacting with their environment in regards to you and, again, several other people being there, that might be something that you might kind of like just raise a flag on. Sexual abuse is really difficult to kind of hear about or actually come up with when you're on scene with a patient. And it doesn't matter if it's a male or a female child, either or could be equally sexually abused. Generally, this might be something where somebody has a different story and there's an injury pattern that's just not adding up. So make sure that we're not dealing with this like in an accusatory manner in front of the parents or the caregivers or whomever is now in care of the child. We want to make sure that we're kind of getting them to the appropriate facility and then just taking significant notes and making sure that the hospital knows what your suspicions are. We're going to kind of go over the SIDS, or the sudden infant death syndrome, and this is the unexpected death of an infant or a young child, and there's really no easily understood explanation for this or direct causation. The leading cause of death in infants younger than 1 year is SIDS. It's impossible to predict SIDS, but the risk factors are somebody smoking around the infant, or the mother smoked significantly during pregnancy, a very low birth weight, or the baby is improperly placed on the stomach with loose bedding, which would cause some kind of asphyxiation. The death of SIDS can occur at any time of day. It's usually discovered in the morning when the parents go to check on the infant, who perhaps they thought slept through the night without any real noise. There are three things that are going to happen there. You have to assess the scene, you have to assess and manage the patient, and then make sure that you're understanding how to communicate with the family, who may ultimately be the patient. If we have a SIDS death and the patient is obviously not viable, right? We have liver or rigor. We're not going to actually perform the CPR on that patient, right? We're not going to put false hope into the family, and this can cause some significant issues. You got to make sure that your communication skills are on point and that you can ultimately be able to explain why you're not going to attempt to resuscitate this child. Obviously, our scene assessment has to be on par. We're going to have law enforcement there, so make sure that you're concentrating on any signs of illness, any kind of medications or things that are going on with the patient who is now deceased, the general condition of the house, and how is the family interacting. You know, for the most part, most of us aren't psychotherapists, so everybody's going to process grief and things like that of different types, and so just make note of it, but that doesn't necessarily make anybody culpable if they're not responding the way that you would respond yourself. Here are some alternative causes for what looks like SIDS. This could be accidental suffocation or strangulation, an overwhelming infection, child abuse, airway obstruction, meningitis or hypoglycemia, an accident or congenital metabolic defect. That's not something that you're absolutely going to go ahead and kind of rule in or rule out. These are just some of the things that may present very much like a SIDS kind of condition. Okay, so like I said, this was a pretty long lecture, and I tried to cut out some of the stuff that was super redundant and we've gone over, or it really kind of bled through towards the adult treatment algorithms, and the disease processes didn't change a whole lot. If there's any questions that you have on this particular lecture, again, when we're dealing with pediatric patients, it's very rare, and generally when we do, they're really pretty sick. So I want you to feel comfortable with it, and if you feel like there's something that you haven't gotten, reach out to me via email or set up a time for us to have a meeting, and we'll go over some of the other additional things. I'm happy to clarify some of that stuff. And in lab, we do a lot of practice with pediatric treatment algorithms from trauma and medical, and we're very, very involved as far as your tools and utilizing any of your treatment tools or systems so that you are appropriately managing a pediatric patient. Again, you really have to be on top of your sizing and your placement for tooling and things like that, and we want you to be good at it because it's really difficult to do when you don't do it very often. So the best way to get the practice is to practice in lab. Again, just reach out and let me know, and we'll get after it.